Good afternoon, and welcome to this installment of the GALEN Healthcare Solutions webcast series. Today's webcast provides a unique experience as we will be co-presenting with one of our partners from SSM Integrated Health Technologies. Together, we'll be presenting the functional and technical considerations in a clinical data migration. I'd like to remind everyone that you are muted when you come into this webcast. You can use the Q&A panel on the right side of your screen to submit questions, and we'll try to get to those at the end of the presentation. All unanswered questions will be posted in Q&A format on our blog and wiki. The agenda shown on this slide reflects the critical considerations we go through in any data migration. For each consideration, we'll touch on how it relates to SSM's migration, the challenges they encountered, and how you can utilize their experience to better prepare for your own. Your panelists today are Sandy Winkleman, Reporting Informatics Manager and Regional Project Manager at SSM Integrated Health Technologies, Managing Consultant Taylor Moyer, and Senior Consultant Kavon, both from GALEN Healthcare Solutions. I'm Julie Champagne, a strategist here at GALEN. I will be moderating along with our VP of Strategy, Justin Campbell. To give you a little background on our organization, GALEN Healthcare Solutions is a healthcare-focused services and solutions company. For over a decade, GALEN has built a solid reputation of providing high-quality, expert-level IT consulting services to health systems, hospitals, and physician practices. Our expertise includes, but isn't limited to, EHR deployment, data migration and archival, application development, and project management. We have partnered with over 300 specialty practices, hospitals, and integrated delivery networks to provide extraordinary patient care and business solutions. We offer a suite of fully integrated products that enhance, automate, and simplify the access and use of clinical patient data within those systems to improve cost efficiency and quality outcomes. Now to get to our main feature, a unique take on our traditional webcast, where we'll use a case study as the framework. We'll look at GALEN's partnership with SSM Integrated Health Technologies during their EHR transition from Centricity and MEDITECH to Epic, including the roles each panelist played in the migration, the challenges they faced, and the lessons learned. Now here's Sandy to tell us a little more about SSM and their migration journey.
Okay, so what this slide is doing is describing specifically our Shawnee data migration, but before I go into that, I just want to give a little bit of background about SSM. SSM Health is an organization that's in 4 states and has a corporate office and an integrated health technologies, which is our IT branch, actually located in St. Louis, but then does cover all the different clinics, hospitals, outpatient areas with the same IT services. So it's all kind of a corporation. Then we have at the regional levels a variety of hospitals, surgical site centers, ambulatory areas, et cetera. So what I'm going to be talking about is specifically in our Shawnee, Oklahoma Epic implementation. We installed Epic in April of 2016 at Shawnee Hospital and then Shawnee Clinics. The clinics are anywhere between 10 feet from the hospital all the way up until about 30 miles away from the hospital for this particular implementation. And what we did is in Shawnee, the hospital itself is a 100-bed licensed hospital with about 65 provider clinics attached to the hospital. And whether they're physically attached or remotely attached, they were historically running an electronic health record, and as far back as about 10 years ago, they had started in their electronic record journey. So what SSM needed to do was integrate the historical information from those electronic records into Epic. And the systems that we focused on are MEDITECH 6.0, which was being used at the hospital, MEDITECH LSS, which was used at some of the clinics, and then the Centricity ambulatory EMR, which was the EMR that was used, again, at some of the clinics. Our target system, as I mentioned, was Epic version 2014, And the way that we accomplished our data migration was using a combination of CCD extracts and then the corresponding reconciliation process within EPIC, and then the importing of actual HL7 messages. You can see from the slide we had, in terms of key metrics, 270,000 immunizations, 360,000 allergies, 650,000 medications, and 600,000 problems that were all brought from the source systems into our targeted system. We migrated 139,000 patients, and 200 plus providers were involved in the migration. So you can go to the next slide. My particular role was kind of five-pronged, if you will, for this particular project. First of all, I was a collaborator in terms of facilitating a lot of discussion with our local facility, so our Shawnee Hospital Administration, our clinic administration, and our physicians and providers, bringing those folks together to talk through our data migration options, talk about what makes sense in terms of what elements to bring over, discuss the timing. So did a lot of facilitation of that collaboration. Also needed to bring together our corporate partners. So SSM Health, as I mentioned, has the Integrated Health Technologies, which is the IT branch of SSM, brought the experts from the core, the system team, into the regional team to help make sure that we were addressing all the technical components, because we had really never done a full data migration to this extent in SSM history. So this was new ground to us. So we definitely need to include our technical partners, and my job was to coordinate that activity. We also did data mapping, where you basically take from your source system, here's the information from your source system, and then how does that actually map into your target system. So writing and helping them address the mismatched items was key to the data migration. Also worked with coordinating the data loads, and you'll see throughout the presentation the importance of aligning the master patient index load, the visit load, the CCD load, the HL7 loads, and making sure that all that flows cleanly. So I had a role in terms of coordinating that load. And then lastly, just the very specific components of validation and reconciliation. And part of the data migration strategy does involve small-scale testing and then full-scale testing. And so having myself, along with my subject matter experts, to actually look at and review and conduct some of that reconciliation with our physician providers was one of those other key roles that I played. Okay, you can go to the next slide. So Kavon, tell us about your role.
Yep. Thanks, Andy. So my role in this migration was as the project manager for the GALEN team. So again, similar to Sandy, but on the GALEN side of things. And data migrations, they're a tricky landscape, and that's simply because they require a meshing of both the clinical and the technical worlds. I think that's mostly where I came in. So having those conversations with my tech team to understand their capabilities and limitations when it comes to both extracting and manipulating the legacy data, and then translating that knowledge to facilitate discussions with the SSM team and their physician champions, so that we could devise a way to migrate the information they needed into their target systems. So that's just one example. Other tasks included guiding validation, so collaborating with the SSM validators to ensure that our testing goals were reached on time, and that any identified issues were retested and ultimately fixed. And then once a sufficient amount of testing had occurred and we were confident with the data, we provided demos for the physician champions. And this allowed them to see for the first time, what the clinical information was going to look like and how it would behave in the target system. And we actually found that these demos helped to alleviate concerns and ultimately created physician buy-in during the migration project. And then finally, just another example that depicts my role in this project, which was to create and hand off training documentation. And again, this allowed SSM to equip its trainers with the tools they needed so that they could prepare end users not just for their EPIC Go Live, but to use the migrated data as well. So next I'm going to hand it off to Taylor. He can tell you about his role.
Thanks, Kavon. My name is Taylor Moyer, Managing Consultant at GALEN Healthcare, working on the technical services team. We focus on data migration, data integration, and data archiving. But for this particular project, I was the technical lead for the SSM migration, mainly responsible and focusing on the extraction, transformation, and delivery of all data migration files for loading into the client's EMR. Throughout the presentation, I'll expand on this. Also, as lead, I was focused on providing mentoring to other technical team members that were assisting this complex migration coming from multiple systems and multiple source databases, and working with them on making sure that we collaborate in providing timely delivery of the data for this migration. And then finally, using our powerful GALEN ETL data migration engine, I was one of the 2 certified GALEN ETL resources that were brought on to help facilitate the technical role of this data migration project.
So for SSM, as I mentioned, we had been rolling out EPIC for our facilities for a number of years, and the typical implementation involved going from a paper record to an electronic record. But with our Shawnee implementation, it was definitely taking an electronic record to an electronic record. And so part of our discussion was sort of what are those pieces that we know that we want to try and grab from the electronic record, but what are those pieces that we know that we will have to abstract, meaning they won't carry over electronically. And in making these decisions, there were some considerations that we had to think through. So first one was just basically access to the source clinical data in terms of who actually has access to that information, how clean is that information, are they familiar with the systems. And so, you know, as any organization is concerned about, when you pull clinicians away from the work that they're doing, it leaves you with a gap. And so what we looked at is, could we potentially pull in some nursing students or some medical students who are at local universities to help us with some of that abstraction activity. So saying to ourselves, well, let's not do any data migration, let's do 100% abstraction. What would that look like? So we kind of built these cost models to figure out, well, is it cost beneficial to bring in outside help to help us through this? In a typical EPIC Go Live for SSM, the abstraction process began usually about 2 months prior to the actual Go Live date. So it's abstracting key pieces of information, bringing that into the record. When we considered an actual data migration strategy and, again, evaluated that cost, we also considered, you know, in terms of validity, accuracy, the cleanliness of the data, and would we get a better result if we actually used the existing EMR and brought that forward. And really, the cost of abstraction far outweighed what we would be spending on a data migration strategy. So that definitely made our appetite for data migration much heartier and much more palatable to our senior execs in improving the project. So again, looking at cost effectiveness of the approach in terms of just what in dollars and cents, and then just from a data perspective in terms of the cleanliness and the accuracy of the information, those definitely played as considerations for whether or not to migrate or abstract.
So going into any new data migration project, such as SSM, we provide our client an assessment of the capabilities of our data migration engine, GALEN ETL, and the processes and procedures that we provide as part of the data migration project. So in a few minutes, we'll discuss the impact of the assessment with the scoping decisions made by SSM that Sandy just mentioned based on cost effectiveness but also continuity of care. But first, we'll briefly discuss our capabilities coming into each data migration. Each client is unique in their approach to migrating data from one system to another, and we focus on providing a menu-like approach to choosing which clinical data elements will need to be brought over to support their continuity of care and migrating different to their target platform. So the decision starts with the legacy EHR, which we typically call the source system, and how the data is stored. Is the data stored discretely? Is it combined into multiple file formats, such as scanned images? Is it spread across multiple tables, or in this case, even multiple databases? In particular, in MEDITECH with their 6.0 inpatient acute platform and their LSS ambulatory platform. The data is further subdivided by the preference in which their target EHR, which we call the target system, needs to be delivered in order for it to go to be loaded for their go live. So this ranges from HL7 messages, continuity of care documents or CCDs that Sandy mentioned in the overview of what was used for this particular conversion. There's also scenarios where we'll use flat files or index files and or scanned images for the data migration as well, such as PDF chart summaries. So now to get the data from the source to target, we insert our GALEN ETL data migration engine into the middle to act as a transformation engine to support those data needs. So as you can see in the graphic, we utilize the healthcare standards mentioned, HL7 CCDs, to deliver a wide variety of data elements to support the data migration. So this list of items isn't an all-inclusive list, but is a great example to highlight the diversity and functionality that we can provide your source system data. Also, if you don't have access to the entire source system relational database, we can also extract or parse clinical data from standardized data sets, such as delivered HL7 files or CCDs to perform similar workflows, but we prefer to work from the source system when available. So this is just an overview of what we can migrate. I'm going to pass it off to Kavon, who's going to discuss how this particular subset was delivered for the SSM data migration.
So as you already found out from Sandy earlier, and as Taylor just alluded to, we didn't migrate every clinical element that we could have. And many of the reasons that SSM opted not to migrate certain clinical elements actually came out of the assessment that we had performed. And so during the assessment, one of the ways we analyzed the data was from a volume versus time perspective. So that is, for each of the clinical elements for the previous 1 to 2 years, what was the volume of data? What about 1 to 3 years or 1 to 5 years again? What was the volume of data for those time frames as well? And the whole point of this exercise was that by reviewing the volume of data on a year-by-year basis and then presenting those findings, we were able to help SSM determine what time frame would capture either the most data or only the most critical data that SSM wanted to carry forward into their target system. Another important facet. Oh, go ahead, Sandy.
Go ahead, Kavon, finish, and I'll add 2 years.
I was just going to say, another important facet that of the assessment phase was to research and determine how each of the potentially in-scope clinical elements would be migrated, and then how they would appear in the target system. So again, would they be view-only? Would they be discrete, meaning that the data would appear as if it were actually documented in the target system? Or would the migrated data be reconcilable, meaning that it would need, action would need to be taken on the clinical element before it's integrated into the patient's EPIC chart? So again, these were the kinds of information that helped SSM determine, what clinical data they wanted to bring forward into EPIC. And then, as it turns out, after that, SSM settled on migrating active problems, active allergies, active medications, and then administered and historical immunizations. And finally, just 2 types of notes, operative and procedure reports.
Yeah, the other piece I wanted to just add to this is, in terms of how do you go about this, we had a physician steering team that was very helpful in helping to decide what information to bring forward. And that was one thing that we really wanted to stress was that, number one, they weren't going to lose access to their historical information because we promised to keep the prior EMR records live in their system. It's just they couldn't write to them anymore. So they would have a legal medical record for all that historical information. second thing is that we had, for example, PACS system going live, and we knew that PACS images would be available through that system, so we didn't necessarily have to bring scanned images over. The other thing we wanted to do was really stress the fact that we're trying to bring information forward into EPIC, into that targeted system for continuity of patient care. So really taking a hard look at what are those elements that are going to help me into the future for taking care of that patient. That's how we were really able to hone down on what specifically is truly needed and how best should it appear in that record. So that's all I wanted to add.
So this slide alludes to the initial phase of every data migration project that we take on at GALEN. In this phase, the focus is on confirming access to your clinical data so that we can then start extracting it into our GALEN ETL data migration engine for evaluation and then comparison with your source system's user interface. There are several challenges that we continually face during this particular phase of access, extraction, evaluation that we aim to help our clients mitigate through planning, discussion, and execution. So those are source of truth, identify potential issues, and then access. So source of truth alludes to which system do we want to use as the source of truth, since there could be a potential overlap. In acute and ambulatory shared or integrated environments, such as what we encountered at SSM, we needed to determine the origin of the migrated data. For example, in a shared platform with multiple data sets, data entry from one platform can migrate through a technical process such as stored procedures or triggers so that the data can appear in both the acute and ambulatory data set, but the origin comes from where the end user initially entered that data. So our goal is to determine which of those two systems that data originated from so we can capture the data from its point of origin into the EMR or EHR so we can modify our extracts to select from the correct location. We found this to be true with medications that were primarily entered on the ambulatory data set that were then transferred into the acute care side, and there were several other data sets that we went through and performed an analysis working with the SSM team, subject matter experts, and our convergent analyst team to identify where when data was entered on the front end of the system, where the data was initially stored in the database and which database it was stored in. The next one is identifying potential issues extracting data. When we start developing our data extracts and reviewing the results, we can run into issues that can be identified without impacting the project timeline and deliverables. We can also run into issues that could potentially impact the timeline and deliverables. So our focus is on triaging those issues to apply fixes or add additional features or functionalities to reduce or eliminate the issues prior to the loading of the data. Sometimes these issues take weeks or even months to resolve, depending on the severity, but we focus on identifying them up front and then continue to provide updates on when the client can expect to see the data delivered. Another purpose of this phase is to apply our lessons learned from previous migrations to identify and mitigate risks up front as well. So an example would be the way that a source system stores blood pressure. Do they store it with unique rows for systolic and diastolic, or do they combine the two? Most target systems prefer to have those two readings combined into one record. So what we need to do is focus on our extracts and whether or not this work needs to be done up front, so that can be identified and delivered for the initial testing phases. So it's really doing the little things up front, such as looking at specific ways data is laid out or how data is converted into the target system, and leveraging our experience to reduce pain points later in the project. And then finally, perhaps the most critical component of this phase is, which is the first one, but saving the best for last, is getting access to the data, and we'll continue to stress this with the next slide. But timely access to data helps ensure the project stays on schedule and that our consultants can begin the extraction process of the data into our GALEN ETL platform. So from within this platform, we can start to evaluate the data along with our conversion analysts and determine how the extracted data aligns with that source data system user interface. So let's take a look at the next slide for a more focused look at access. So as I mentioned, one of the most critical parts of a data migration is how quickly and effectively the data migration team can gain access to the source data and application. So source data access entails the ability to query and extract the data from the source system that is being migrated, and typically means that we have direct access to either a copy of the data or direct access to the production database itself, such as Oracle or SQL or MySQL. The source application access typically refers to typically read-only rights that allow us to confirm that the data we're extracting from the source data aligns with what the end users are seeing on that application side. So this helps us prepare for the later rounds of testing when not only we're looking at it, but we allow the clients to get a glimpse of the data that we're migrating for them. The remaining parts of the project also depend on timely access, because delays in access may require the timelines to be shifted or even require additional effort than what was originally scoped. And I believe, Sandy, you have some feedback that you wanted to pass along regarding your experience with the issue of access.
Yeah, a couple things. One is just making sure that it's very clear that we know specifically what is the access and the amount of time that's needed, because, you know, again, we're just like anybody else wanting to make sure that our systems remain secure, and so that was an important thing to be very clear about. You know, we had all the necessary BAAs and contracts signed and whatever, but making sure that we understood that piece was important. I think another thing that is important when you're looking at access, and I've just drawn a blank. We can go to the next slide. I'll come back to it.
Well, I've got, maybe this will jog your memory, but so, you know, we've done a lot of these projects, over 200, and so there's different ways that you can approach access, and so I've jotted down just 4 quick ones to just highlight because of their importance in turning around access for the team for starting off a migration project. And so a couple of these are an on-site kickoff that focuses on not just the project overview, but focusing on access and working on-site with the client and their team to gain access. So one of the goals being, by the time that the on-site kickoff is complete, we'll have partial or full access to the systems on-site and have been able to validate and test it on-site as well. And another one is ensuring that the access to security team at your organization is part of the project discussion during the scoping or the later phases of the project. Oftentimes they're brought in after everything's been completed and handed off a project that we as the consultant would like to get started on right away, but there has to be a ramp up for the security access team. Another one is somewhat obvious, but I think it underscores kind of the importance in getting all parties involved to focus on access as soon as possible when the project is signed and the kickoff is started. And then also the communication of the needs and not the wants for access. So what are the access requirements that we as the consulting firm needs to ensure that we can pinpoint those specific items so we don't try and overstep our access once, which may kind of run up against some particular security policies. So if we can focus on our needs for access, that allows us to focus in on what we really need in order to ensure success for the project.
Yeah, and I'll just add to that. You know, I have to say I was very impressed with GALEN's knowledge of both the targeted system being Epic, and then those source systems being both MEDITECH and GE Centricity, because they were able to very clearly say to me what it is that they need access to, which then I could then submit the necessary paperwork and have our security team make sure that that's granted appropriately. So that was really a nice thing, is to have someone who really knew both systems, you know, to facilitate getting the right things to the right people. So that's really actually what I wanted to add.
All right. So moving on this slide, you can see some of the statistics that were specific to the SSM migration. And so these are stats that we hand off to all clients when we're aiming to attain sign-off before loading data into production. And through discussions with SSM, we had developed criteria to identify which patients should be included in scope, because we only wanted to generate CCDs for those patients. And so what we ended up with was we defined active patients as any individuals that had had a problem, a medication, an allergy, or an immunization added or updated in their legacy charts since 2 years prior to SSM's Epic Go Live. So that was how we arrived at our patient population and the total CCD counts that you see on the slide for both MEDITECH and GE Centricity. And likewise, we've also included total counts of the in-scope clinical elements. So again, this was something that Sandy touched on at the very beginning of the presentation. But again, just to go through a few, so for MEDITECH, we migrated, approximately 279,000 allergies, 164,000 problems, 355,000 medications, and then so on. And again, these total counts of a given clinical element migrated from each legacy system. That's what you see in the second column, the total counts column. The next two columns are depicting codified counts and then the percentage of clinical elements that have codifications associated with them. And so when I say codification, I'm referring to our SNORM codes for allergies, ICD-9 and ICD-10 codes, SNOMED codes, NDCs, et cetera. And all these codes have they've been created to serve as a coherent, standardized language across not just EHRs, but healthcare entities as well. So the question is, why are these important, and what do the percentages that you see on the slide tell us? Basically, these percentages allow us to gauge, what portion of the migrated clinical elements will be auto-mapped based on codification. And therefore, these percentages are representative of the effort that's required to manually map these elements when reconciling the data to the patient's Epic chart. And as you can see, the percentages are very high across the board, both for GE Centricity and MEDITECH, except when it comes to allergies. And the percentages for allergies are likely lower due to a majority of non-medication allergies being documented. And as we know, non-med allergies don't have RxNorm codes. So initially, you would think maybe this would be a problem, particularly as it pertains to allergies, but not necessarily, because when importing the data, while Epic does first try to match allergies on codification, it does have a secondary feature, which is to match allergies based on the exact spelling. So despite the low percentage of allergies in MEDITECH and GE that have RxNorm codes, a large percentage are still expected to be matched based on spelling. So when you're looking at those percentages in the columns, again, they represent what would be, quote unquote, the worst case scenario.
Right, and
likewise,
so Kavon, just to add to that, so part of what our physician coordinators did was where we didn't have a perfect match, they were able to say the equivalent thing would be something, something, something. So in some of our source systems, some of the text had maybe 2 allergies in one field, and so it was a matter of separating them out and matching them discretely, or using them in combination to match to an in combination entry in Epic.
And just to round out the slide, I was going to say, you can see because of the high percentage matches with problems and medications, SSM could then expect, that a minimal amount of effort on end users' parts would be needed to manually abstract problems and medications during reconciliation workflows. So on the previous slide, we had talked about the auto mapping of clinical elements, by leveraging codifications, and that actually feeds us into the next stage, which is the manual mapping of clinical sub-elements. So during the data mapping phase of the SSM project, we mapped allergy reactions as well as medication dose units, medication routes, and medication frequencies. So that's what I'm referring to when I say clinical sub-elements. And what I mean by mapping is that something Sandy alluded to, we would take the legacy system allergy reaction. So for example, say swelling was documented in the legacy system, we would take that and we would map it to an equivalent reaction in EPIC, such as edema. And the process also occurs for medication sub-elements. So again, mapping milligrams to milligrams for medication units, mouth to oral for route, daily as needed to daily PRN for frequency, and so on. So that each of these sub-elements can be imported into EPIC and then they'll parse discretely. Where this stage can get challenging is when there are not one-to-one matches between the legacy and the target systems. So for example, should an allergy reaction of facial swelling in the legacy system be mapped to a more general reaction of swelling or edema in the target system? Or is that specificity that is, the location of the swelling, is that clinically relevant? Is that something that the physicians need? So this is where clinical input and review was needed from the SSM physician champions to determine what approach we wanted to take. Another challenge that had presented itself during the mapping phase was, just the sheer volume of data that we're dealing with and trying to map. And so to overcome this, we first focused on mapping sub-elements that are used most frequently, and this allowed for us to ensure that the majority of sub-elements would parse discretely in EPIC before moving on to the less frequently or rarely used sub-elements. If a particular reaction or dose unit is only used once in the legacy system, the question is it really worth the time and effort it takes to map something like this? And then where do you draw the line? You could go on mapping forever, so at what usage do you stop? So again, these were discussions we had with SSM during the mapping process. And then just a few more challenges to touch on, which are mostly workflow related. We had to determine what SSM's best practice workflows were to ensure that we were migrating the data to fit in with those workflows. So for example, discussing the pros and cons of migrating no known allergies as an allergen or migrating it so that it isn't reconcilable in EPIC. And ultimately, through discussions, SSM decided to migrate no known allergies so that it would be view only on the CCD report. And then the end users or physicians would be prompted to check the no known allergies checkbox in EPIC. Another challenge, which actually relates back to an example I had mentioned earlier regarding allergies. When I mentioned the scenario where there was an allergy reaction of facial swelling in the legacy system and whether or not it should be mapped to a more general reaction of edema or swelling in the target system, there was actually another option which I left out, and that was to leave this reaction unmapped. And by leaving a reaction like this unmapped, it would come over as facial swelling and it would appear as an unmapped free text reaction in EPIC, and then the end users would be prompted to manually abstract this reaction when they're reconciling it in EPIC. And at that time, they could add the additional specificity or the body location that was needed. So again, through discussions, letting SSM knowing the pros and cons of this situation, that approaching the migration of allergies in this format does create added effort. Despite that, SSM did ultimately pursue this option because the clinician simply felt that, that the specificity of the body location was important and that it was needed. All right. Once again, on this slide, we have some more statistics, which were specific to the SSM migration. Where these stats differ from what we discussed earlier is that they're referring to the manual mapping effort that was taken on by the GALEN team. And so this mapping effort was associated with sub-elements of allergies and medications. So again, manually mapping allergy reactions, medication dose units, routes, and frequencies, et cetera. And the first take-home message from the slide is that by mapping these sub-elements, we were able to save SSM and users a lot of time as they wouldn't need to manually abstract this information in EPIC. It would simply parse discretely. And the second point I wanted to make is actually related to legacy system limitations. So as you can see, the percentage of mapped data for GE centricity is much lower across the board, and this is due to two things. So for allergy reactions, GE centricity allows for free text entry of allergy reactions, and the use of this free text capability was much more prevalent in GE than MEDITECH. And because of this, there were a lot of unique, rarely used reactions. Makes feet turn blue or makes me feel sick. Endless possibilities, essentially, of reactions documented. And so items like these, they don't really have a clear equivalent in EPIC. And because of the prevalence of these free text allergy reactions, the percentage that we were able to map, it appears lower. And then when it comes to medications, the way in which GE centricity stores the data created added difficulties as well. So when it comes to the extraction and the mapping process, in order to map any prescription instructions, we had to extract the entire free text SIG and then map dose and dose unit, route, and frequency based off of that. And many of these free text SIGs from GE centricity, they simply didn't contain a dose unit or a route, for example, and therefore there was nothing for us to map. So there was simply a large number of medication instructions where mapping certain elements wasn't appropriate. So that's why the percent mapped appears lower. And then the final thing I wanted to touch on in the slide is the last column, the one labeled SSM validated. And this points just to another piece of the data mapping process in the GALEN methodology, which is that once the GALEN team has made a first pass at the mappings, we hand them off to the client to have the clinical appropriateness and the accuracy of these mappings reviewed. So this was another process that we went through with SSM. All right, and then once mapping was complete, we were able to move on to the next phase of the migration, which was validation and testing. And essentially the goal of the validation process is to satisfy our quality requirements by ensuring that an appropriate number of in-scope clinical elements in patients are tested. And the first phase in the validation process is small-scale validation. And this is a process that's undertaken by the GALEN team only. And essentially the goal during small scale is to uncover any issues that may be widespread while also testing each of the in-scope data elements. From small scale testing, we move on to large scale, and this is when we enlisted the assistance of the SSM resources as our testing goals are larger. So similar to small scale, the goal here is to uncover and fix any issues. And then usually with large scale, because we're incorporating the client team into the validation process, we set up a validation training session, and then we'll hand off validation instructions to help familiarize the client resources with the validation process itself. And then finally, after large scale, we have the last phase of validation, which is full-scale testing. And the key aspect of full-scale that I want to touch on is that during full-scale testing, we perform full-scale data loads. And the purpose of doing this is to get a better sense of the timing involved in extracting and generating each of the in-scope data elements, practicing handing off and delivering the data, and then finally practicing loading the data for the entire in-scope patient population. So essentially, these full-scale loads are serving as a dry run production data loads. All right, so those were the various stages of the validation process, but one other thing I wanted to discuss are the types of testing methods we deploy. So on this slide, you can see our testing metrics, which we track throughout the validation process. But what these metrics do not capture are the other types of testing that we perform. So while GALEN's validation methodology consists of several phases of testing, which I just reviewed, we also deploy other testing methodologies to ensure, that we are safely migrating data and that the integrity of that data is maintained once it's loaded into your target system. So one of the methodologies that's not captured in the validation metrics that you see is focus testing. So what is focus testing? Basically, throughout the validation process, GALEN performs data testing where specific scenarios that could cause or that could result in issues are identified and then tested. So for example, testing multiple examples of every mapped allergy reaction, every mapped medication dose unit, route, frequency, et cetera. And similarly, some other scenarios include testing patients that have mapped and unmapped allergy reactions to ensure that the loaded data is behaving appropriately, testing patients that have an allergy with more than one mapped allergy reaction, et cetera. So again, these are just a couple examples from a very, very long list of scenarios that are tested behind the scenes throughout the validation process.
Thanks, Kavon. I'm going to talk about the final phase of a data migration, and I'm going to try and move through this a little bit faster just to make sure we have time for Sandy's lessons learned at the end. So the final phase is a data loads and go live, which entail the process of populating a set of validated, tested, production-ready data and loading it into the target system. Further supported by subsequent gap loads of the data between the delta of time between the production, extraction, and delivery of files and the go live, the client's go live date, where there may be a time frame of that it takes to generate that data and deliver it. There may be a week or month or multiple months between when we deliver the data and when the organization goes live with the target system. So our focus with the gap data is to provide exactly what it says it is, the data between that gap period that we can load in so that by go live, the data is up to date with the data entered in the system the day before or a couple days before the go live. And then post go live, there's usually some clients that have to have notes signed or documentation entered into the source system. So anything that's entered in after the organizations go live and when the source system is set to read only, we want to make sure we capture that gap data as well. So that's the focus of the last approach that ends with the completion of the data migration. But so the three challenges I wanted to just to highlight and discuss for this particular phase and can be mitigated through thoughtful planning, a technical approach, and then strong project management on both sides is extraction versus abstraction. So these two timelines hold key project plan considerations as they pertain to hard timelines and deadlines that we need to meet in order to keep the project on schedule. So extraction timelines are associated with the time that it takes to pull the data from the source system, transform that data, and then provide it in the format that's requested by the client for the target system. Abstraction timelines are generally provided by the client. In this case, it was provided by SSM, but focus on the time it will take their team to reconcile the loaded data into their target system prior to their go live. And this particular project faced unique timelines brought forth by the time needed for their abstraction that required us to shift our focus and delivery of certain data elements in an adjusted timeline. The second one is the master patient index, or MPI loads, that can either be performed by GALEN or the client, but contain the demographics that are not only brought over to EPIC, but are also used to match the migrated clinical data. This data set is the primary record that's used to establish that patient in the target system and becomes more complex with the more systems that need to be migrated and kept with some form of integrity. And then finally, the timing or overall life cycle of the migrated data and how all the components of a data migration project come together and to deliver the data to ensure that the project is in place when the client expects it to be in place. The next slide does align with some of the MPI complexities. It's not a new phenomenon, but it is essential to a data migration plan and a migration plan to a new target system in general, especially one that contains patient data from multiple systems that are being consolidated into a single repository, such as EPIC or Cerner. We've encountered the following scenarios with MPI loads that can impact data migration. I'm going to run through these, and then then Sandy is going to give some feedback from her particular experience. So the scenarios that we see, patient matching issues when filing data against using the source systems MRN. There's been data that's been entered into the target system, but for some reason the source system MRN may have changed, and there's a misalignment of that data and troubleshooting that. We've also got the MPI load itself. So much like a data migration where we provide an initial load of the data with subsequent gap loads, there's also oftentimes an initial load of the patient MPI with subsequent gap MPI loads in order to catch up that MPI in the target system with the patients that have been added or modified or merged since the initial load. And then addressing both of these, you have the multi-system complexities, dealing not just with one system is hard enough, but once you start adding multiple source data sets and combining and creating that one record, just further adds the complexities of that. So we can't stress enough that your MPI load is important to just your migration overall, but also how it impacts the migration of the data that's coming over so that that data lands with the right patient. And so Sandy's lived through this and probably has some examples she can discuss in relation to her project.
Yeah, we encountered a little hiccup with our MPI load in that we have patient records, or patients that have multiple medical records because of the history of the EMRs and the various EMRs we were bringing forward. And the hiccup was that a setting in Epic said, oh, we're only going to take one medical record number. And so then we had this corresponding mismatch of visits, and we couldn't figure out why all these visits weren't coming over. Well, when we kind of did a very quick root cause analysis, determined that we were just limiting the number of medical records. As soon as we opened that back up, things really flowed, in terms of matching the patient to the visits, and then that could correspondingly match to any of the HL7 and CCD information. So it's very important to really understand that what information is coming out of your source systems to make sure you've captured everything correctly. So that's about the best example I can explain about some of the challenges with MPI information.
Yeah, I think they can be limitless depending on the system and the complexity. So thanks, Sandy. So the next slide is based on kind of the overall timing and the life cycle of data migration. So this encompasses the process from a technical perspective. It really highlights visually the discussion and path of what we've just spoken about, talking about the extraction, how we utilize GALEN ETL, the mapping, the importing, the transferring of the data, all to be ready for the go live and decommissioning of the legacy system. Really this is the graphical representation of what we've been talking about for the last 30 minutes. And due to time constraints, I really want to focus on the end and the lessons learned. So I'm going to pass it on to Kavon to finish his time slide.
Yep, so on this slide, this is just a graphic representation of the timeline. And I think, just the busyness or the complexity of this slide kind of points to many of the challenges that we've discussed throughout this presentation. So, I mean, as you can see, we had approximately 2 months time frame from the initial extraction process in December to the abstraction go live in mid-February. And this created, a time crunch in terms of making sure that we were able to meet that initial abstraction go live. And then just another thing to point out, we do generally aim to complete 2 rounds of large scale and 2 rounds of full scale testing, but as you can see on the timeline, just to accommodate that time crunch, we were only able to do 1 round of each. So testing all of our patients in 1 round of full scale and then 1 round of large scale was a challenge in and of itself.
So in terms of overall challenges with the project, I think we've said it plenty in terms of really understanding what are those elements that are needed going forward with patient care in terms of understanding that every piece of information has a certain cost to it and what is that corresponding benefit. So weighing the cost versus benefit, that was definitely a challenge because we had no model really to work from, and now having gone through it, really, I would feel much more confident for a next go live to know the conversations that we need to have, and that would definitely cut down that cycle time. The other thing is just gaining the necessary approvals and agreements from multiple stakeholders. So making sure we've touched base with our provider community, with our leadership community, and then our very technical resources, as well as our consultants, because they truly have been through this more so than ourselves. And so making sure that we've got agreement and approval from all those individuals. It was a challenge, but obviously we did overcome it. I think, again, knowing what I know now, that cycle can be much shortened. And then lastly, the migration versus abstraction activities versus the go live, and knowing that we definitely needed to move our migration up by 2 months from go live date really crunched truly the amount of time that we had to spend. So those were definitely key challenges that we faced. In terms of lessons learned, so there's 7 basic lessons. You know, when GALEN approached me and said, would you help us with this? And I said, absolutely. And I said, if we can talk about lessons learned, I think that would be great. And so these were 7 of them that just came to mind right away. First of all, migrating data can lead to definitely reduced abstraction time. And in my experience, the day of go live, we had, you know, X number of patients in the hospital that needed to have meds, allergies, problems all entered. Well, because we had done the migration, we did not actually have to spend very long doing that because that information had already flowed over. So the actual go live was significantly shorter in terms of the amount of information we had to enter for those hospitalized patients. Another key lesson we talked about is the MPI and visit loads. Make sure they're complete, up to date, and clean. Next, begin your migration process early. So the sooner you can get started, the better. Make sure that you have a process for agreeing on those elements to abstract versus those elements to migrate. Make sure you have physicians and subject matter experts that are available to you as data champions, providing their expertise. That's definitely a lesson learned. And then lastly, make sure your migration and abstraction strategies truly do work hand in hand. So the efforts that you're putting forth in terms of migration will then help and make your abstraction efforts go much more smoothly, since it's more of a reconciliation rather than a straight data entry. So those, in my thinking, were those key lessons learned from this particular project.
Okay, let's now transition into the Q&A portion of the webinar. Sandy, Taylor, Kavon, thank you for your insights, sage advice from lessons learned with the SSM project. We have a few questions that we are often asked with data migration projects and people who have inquired to us in the past, and we want to have Sandy run through those. But we highly encourage anyone, if you have questions, please enter those into the Q&A session, and time permitting, we will pose those to our panelists. So in the next slide, we've got 3 questions lined up for Sandy, and Kavon and Taylor, I'll ask you both to chime in as well. First thing, Sandy, a lot of groups grapple with this. How did you decide on the number of years of data to migrate?
Well, it was basically, again, a cost versus benefit decision. Tapped into the expertise of the GALEN team in terms of what have other clients done, but then I really asked our providers what made sense in terms of a clinical decision. You know, is 4 years too much, 3 years too much, 1 year too few, et cetera. So really having that that good number of a 2-year, and we actually agreed for that for all of the historical information loaded. So it wasn't 3 years or 2 years for medications and 1 year for problems. We really tried to stick to a consistent number.
Very good. And knowing what you know now, what would you have chose to migrate, or would you have chose to abstract? I know that was an initial decision that the organization weighed. What is your perspective looking back?
But, you know, I am an IT person, so of course I'm going to look to migrate, but understand that it does need to be reconciled. And I appreciate what EPIC does in terms of the reconciliation process as that sort of verification of everything. Would I do anything differently? I would like to not have had so many data loads, because we had CCDs that were appearing more than one time per patient because of the different MPI loads and then corresponding CCD loads. So if I could do it over again, I'd probably say, let's try and get everything known up front so that we can minimize the number of loads that we had to go through.
Great, thank you for that. And finally, what was one of the unexpected benefits of data migration? Were there any downsides to it that you saw?
Well, like I mentioned, you know, at the go-live day in the hospital, you know, we set aside a very large portion to get all the medications entered, to get those problems entered, to get current treatments entered, orders entered, et cetera. And that portion of the day was significantly lessened because we had so much information already migrated. And not only just the clinical pieces, but the patient demographic pieces were also in our record already. So that was definitely a plus. On the downside, it was interesting to see how much free text we actually had in our EMRs, in our source EMRs, which I think people were surprised about. You know, of course, the downside with free text is it's not easily mappable, and so that was just a challenge, but overcome.
Great, thank you. And Sandy, I believe you have one key message to the audience you would like to impress upon them.
Yeah, you know, here, just assess your data needs before you actually jump into the project. And this is where, again, knowing that you can't, everything, like I said, has a price tag. And if you want to pay the price to bring everything over, that's great. If you don't want to pay that gigantic price, really think about what are those elements that are going to help you care for that patient into your next EMR, and really think about that information, have that lined out, and then begin your data migration strategy.
Very good, thank you. And we did have one more question I wanted to address, if possible. So whomever's, Sandy, Taylor, or Kavon, if you want to field it. An attendee had posed a question: how did you address cross-indexing of different MRNs? So Taylor, I think you covered that in the MPI slide. But when you had different MRN numbers, maybe for the same patient, how was that handled?
So I can actually address some of that. In EPIC, there is an identity record, and that identity record allows it to store more than one medical record per patient. And so by now having that, that set so that it would definitely store more than one, that's how we were able to achieve that. And it identifies what the source system was that it was storing, that was producing that medical record number.
Very good. Thank you for the response. All right, well, to our panelists, Sandy, thank you so much for spending time to talk through this project. Likewise, Taylor and Kavon, we certainly appreciate it. We will be publishing the slides and the recording at the conclusion of the webinar on our blog and our wiki. We'll send out links to attendees and registrants. To learn more about upcoming GALEN events, please visit our website and select the events section from the drop-down. We look forward to seeing you at a future GALEN Healthcare webinar. Thank you.
Thank you.